And I'll hide myself when you're on, Zeke.
Okay.
All right. Good evening. My name's Jim Wilson. I want to welcome you to the third of 10 webinars on the science, the policy, and politics of the COVID-19 endemic. I'm currently faculty member at the Perlman School of Medicine at the University of Pennsylvania. I'm also a proud alum of Albion College, who's the host of this. This webinar series is indeed sponsored by the Leeson and James Institute of Medicine at Albion College. Before we get started, I just would like to review the format for this evening. After our featured speaker makes some introductory comments, I'll introduce 4 students from Albion who will lead a discussion with our featured speaker. I'd also like to invite Q&A from the audience, and I'll be watching for those questions to come in, and I'll pass them over when appropriate. So without further ado, we're going to get on with the webinar today, and it really is a distinct pleasure to introduce a colleague of mine at the University of Pennsylvania, Ezekiel Emanuel, who at Penn is the Vice Provost for Global Initiatives, the Diane and Robert Levy University Professor, and the Co-Director of the Healthcare Transformation Institute at Penn. Zeke and his family has its roots in the Midwest, in particular Chicago. He got his undergraduate degree at Amherst College and then went to Harvard, where he received his MD and Ph.D., staying on as a faculty member before he then went into government service as the chief of the Department of Bioethics at the Clinical Center at the NIH. It was there also that he had a major impact on healthcare initiatives that came out of the Obama administration. Zeke, then we were able to recruit him to Penn in 2011, where he has been since. So again, it's a pleasure to have Zeke here. Look forward to his comments and the discussion, and I'll pass it over to Zeke.
Thank you, Jim. Really wonderful to be here. So I'm just going to spend a few minutes talking, since this is co-sponsored, I guess, or the students are part of public policy, to talk a little bit about the difference that good public policy makes. And I'm going to do it by looking at some epidemiology. So if you look at the number of cases, Italy was the first Western country to really get hit hard by COVID. Cases went up in early March, and in the second week of March, Italy initially closed the north because that's where the cases started in Lido near Milan, and then a day later closed the south, a pretty stringent lockdown. And what you look, if you look at their epidemiology, and I probably, if I had been smart enough, would have taken the slide of this. But if you go to the New York Times COVID tracking site, you can see they peaked and then they came way down. And about the end of May 25th, 26th, 27th, they were very, very low number of cases per 100,000 population. And they had this big peak and then they've come down. And they've been down all the way until the end of August, really, when there's been another blip, mostly because of vacationers, people going to the waterfront, to Sardinia and other vacation spots, and ignoring all the public health rules, partying, drinking in bars, and that's caused the blip. On the other hand, if you look at the United States, we started about a week behind in New York, in Italy. We went up, came down, but we never went to zero the way Italy, or close to zero the way Italy did. We sort of plateaued out at about 40 or 50 cases per 100,000, and then have gone up as the virus moved from New York down to the south east, southwest, west, and then up the Midwest. And we have not had a period where we've been anywhere near as low as Italy has. One of the consequences of that difference in response has been difference in death. So if you look at the United States, we've had about 56 per 100,000 in terms of mortality. Really, really high, 200,000 now. Italy's had slightly higher than us, 62. And the reason is that big peak in March going into early April. But if you look at the number of deaths since May 1st, Italy has had substantially fewer than the United States. If we actually followed Italy, we would have almost 70,000 fewer deaths, 70,000 people still alive. In just 4 months, we've had 70,000 excess deaths. The difference between us and Italy, that's really the difference between leadership in the political level, public health measures, and really, really sticking to the public health measures, not rushing to open indoor dining or indoor bars or beauty salons or indoor gyms. And that's a case of where you can see public policy really making a difference. And if you encourage people to adopt the public health measures that we know work, you penalize them for not adhering to the public health measures, you can really get your arms around this pandemic until we get a vaccine or we get a preventative treatment. But if you don't take it seriously, you make fun of masks, you make fun of staying separate, you urge schools and restaurants to open very early and very fast, you never get down low, and you end up with many, many, many more people dying and many more people having to suffer the inconvenience and the problems related to the pandemic, wearing the mask, not having children in school, and all the other things that we seem to be suffering. So good public policy, good public health measures instituted for a short period of time, 8 or 10 weeks, can really be transformative in this pandemic. And you can see that by comparing the United States and Italy. You compare the United States to France, the United States to Spain, and many other countries have done even better. Canada, less than half the number of deaths we have. Australia, 1/10 the number of deaths we have. All right, with that, I'm going to end introductory comments, and I'm really looking forward to the question and answer, and I suspect that's going to be your favorite part too.
Okay. Jake, well, listen, thanks for those comments. And at this point, I'm going to introduce the Albion students who will be leading the discussion again. For those on the in the audience, send in your questions and I'll take a look at them. So Jennifer, can you introduce yourself, please?
Hello, I'm Jennifer. I'm a senior here at Albion. I'm from Southwest Detroit. I'm a political science major, and I'm involved with the Wilson Institute for Medicine and the Ford Institute for Public Policy on campus.
Great. Fiona?
Hi, I'm Fiona. I am a junior here at Albion. I am from Lathrop Village, Michigan. I'm a political science major, and I'm also a concentration in the Ford Institute.
Okay. Next, we have San.
Hello, everyone. My name is San. I'm a senior from Vietnam, and I'm double majoring in biochemistry and music, and also involved with the Wilson Institute of Medicine.
Great. And finally, we have Krisha.
Hi, my name is Krisha. I am from Chicago, Illinois. I am a senior here at Albion College, and I am a biology major. And I am also a part of the Wilson Institute for Medicine.
Okay. Well, the students, if you'll stay on now, I'll pass it over to you. I think we're going to get started with San.
Hi. So recently, I read your newest article about the fair priority model for global allocation of vaccines. And Sorry, it was a train. So I was having a question about like, what do you think, like how a country limited financial resources, or like if they have controversial political system, could possibly influence on the fair distribution of vaccines? Because in your article, you mentioned like how COVAX, I don't remember what it stands for, but how they're gonna distribute it.
So to give your fellow students who may not have read the article, we tackled what has been a serious question with, I don't want to brag, but no answer. If in the international setting, when you have a medical resource, whether a treatment or a vaccine or even a test that is in short supply and scarce, who should get it, and how do you ensure that it's distributed among countries? A lot of people in the COVID pandemic has said that a vaccine should be distributed fairly and equitably among countries. And when you read those articles or pronouncements or op-eds, no one actually defines fair and equitable. They simply repeat the word. So our task was, I collected, assembled, I guess, 18 ethicists and public health people and others, and I said, what would fair and equitable allocation among countries look like? Not within a country. It's not like which American gets it. It's like how much goes to the United States, how much to New Zealand, how much to Canada, how much to Peru, to Brazil. And so what we said is that there are three important principles. Principle one, limit the harm. Principle two, mitigate disadvantage. Don't compound disadvantaged groups. And principle three, give equal moral treatment to individuals. And we recognize that in the case of distributing it among a vaccine among countries, you would distribute it to countries, not to individual people. But the goal of distributing a vaccine is to help people, not to help the country necessarily. So you want to help people. So we said that the first goal of distributing a vaccine should be to reduce the number of premature deaths, deaths of younger people. And we made a recommendation to how to measure it. Once you have the number of deaths under control, you then move to mitigate the economic harms, mitigate the unemployment, mitigate poverty, mitigate the loss of income, mitigate the loss of education. And then the third phase is to reduce, is to get to herd immunity so you can return to normal. And we said, well, you know, one objection should be, should you distribute the vaccine among countries on a condition, the condition that the country be democratic, or that it guarantee that it's going to distribute the vaccine fairly. And what we said is, since the goal is to help people, we should be hesitant about intervening too much, because there are some not very democratic countries that might distribute the vaccine fairly and might distribute the vaccine to reduce premature deaths, to reduce poverty cases. And so we thought it was fair to give those countries a vaccine, even if they weren't democratic. We did, however, say if they then abused the vaccine, if they didn't distribute it to reduce premature mortality, but kept it for the senior government officials and the military, they probably shouldn't get round two. So that's the answer. I mean, I'll be honest, the country we had in mind was North Korea.
Fiona, I think you had a question about corruption and fair priority model. Maybe you could expand on that.
So continuing off of what you just talked about, I wanted to know what types of preventative measures should take place to avoid and also to identify corruption when using the fair priority model.
We didn't spend a lot of time thinking about corruption because of the way it's likely that this vaccine will be distributed. The corruption might happen in a country. And if it happens in a country, and if what San mentioned, the COVAX facility, which is a combination of the World Health Organization and Gavi. Gavi is an organization to buy vaccine and distribute vaccines, not just the COVID vaccine, but other vaccines among low and middle income countries. And it's done a remarkable job. It's probably, not probably, it's definitely saved millions and millions of people over, it's nearly 20 years old. The COVAX facility will have to monitor corruption and monitor that when they send it to a country, 10% doesn't get, sold off at high rates by corrupt government officials. I would have to say, I don't know what the number is, but some corruption may be tolerable, frankly, because none of this is perfect and many of these countries are corrupt. But too much corruption does undermine the sense of fairness and equitable, and you would stop sending vaccine to a country. If you're going to push me, what's that level? I'm not sure, standing on one foot or sitting on a chair in front of you, I could tell you, 10% of the vaccine siphoned off, that's enough. But it's something like that. What you really want to avoid is undermining public trust and public sense of the legitimacy of the process. And you also want to, there are many other countries that need it. So if this country's not doing a good job, we'll send it to another country that could use it and, might do a better job.
Jennifer?
Yeah, so kind of leading off of that, I know you talked about your model aimed at looking at a global scale, but I was kind of curious to see if you had any insight on how you think it might be implemented in the US, and like who do you think would get the vaccine first and maybe who should? Because I know there's been a lot of talk about, well, should first responders get it first since they're on the front lines, or should the most vulnerable get it, or people who can pay for it should get it? So I was just wondering your input on that.
So yeah, and again, when you think about distribution among countries, it's among countries, it goes to the country, and the country then decides how they're going to distribute to individuals. The National Academy of Science, Engineering, and Medicine, of which Jim Wilson and I are both members, has been asked to look at the question of how to distribute the vaccine in the country, and they've come out with a preliminary report. I think I'm supposed to get tomorrow their final version to critique before it gets finalized. So the penultimate version, the one but last version. And their priority setting is that frontline healthcare workers get it first. That's about 15 million people. And then frontline first responders, high-risk first responders, policemen, firemen, public transport EMTs. And that's about, I think it's about 2 million additional. And then in the second, well, that's tier 1A, and tier 1B are people with comorbidities, older people living in assisted living facilities. And then and then tier 2 includes school teachers and staff at schools, prisons, and other groups. Now, I've written an article in JAMA that looks at that, and a lot of people think frontline healthcare workers, their top priority, but you have to ask yourself, they're not really at high risk, because now with good PPE, knowing how to put on and take off PPE, they're not at serious high risk. Should they be at the top of the list? Or should we focus it more in high-risk communities that have a high rate and a high rate of COVID, high rate of hospitalization, high rate of death, and that would be more likely to be minority communities. So I'm tending to disagree. The other thing that the National Academy said that we did strongly disagree with was people who participate in the vaccine studies. So they ought to be at the top. They're taking a sacrifice and some risk to participate in a study that'll help us all. I like the sentiment, reciprocity. I think it's right, but I think it's wrong to do it in a public health emergency. It's right to do it in other cases. So I'll give you another case. Distributing organs for transplantation, livers for transplantation, it's a scarce resource. 15,000, 16,000 people are waiting for livers, and we don't get that many each year. We get about 6,000 for transplantation each year. In that case, someone who's given an organ, doesn't have to be a liver, could be a kidney, they should get to the top of the list, in my opinion. Reciprocity should work in that circumstance. But in a public health emergency, I don't think it's a good principle. Plus, they're not the only people making sacrifices and taking risks. People who participated in drug trials, they're taking sacrifices and risks. Why don't they get a vaccine faster? People adhering to other public health measures are helping to keep down the rate and saving other people's lives. Why don't they get vaccines sooner? So I'm not sure I agree with that principle. Now, if you think about it, if what you're trying is not to save the most premature deaths, if what you're trying to do is to save, is to get to herd immunity, you might actually put at the top of your list, immunizing young adults and people who are more likely to spread the virus. So you got to think about what your goal is. One of the things we do believe is that the 3 ethical principles, limiting harm, mitigating disadvantage, and equal concern and respect or non-discrimination, they ought to be the core ethical values, both internationally and domestically.
Yeah, I think it'll definitely make for an interesting conversation once we get to that point to see how the US decides to do it. Thank you.
Well, it's not only an interesting conversation. Let me say one other thing. This is an interesting case for those of you who are in the public policy frame of mind. It's an interesting case of ethics and implementation. So let me just pose a dilemma that I'm not sure the National Academy took into account, which is just imagine the problem of trying to identify someone with 2 comorbidities. So I go to a vaccination site and I said, all right, you know, I need a vaccine. And what are they going to say? You know, we're only giving vaccines to people of any age with 2 comorbidities. It's like, well, how do I prove comorbidities? I bring my insulin and I bring my cholesterol lowering drugs. I mean, think about how hard that is. Now, age is easy. Whip out your driver's license, just show them your age. We know how to do it. Or people in nursing homes, just go to the nursing home. But you got a health problem. And here's another complication. You're not going to be going, for reasons we could talk about, you're not going to be going to your doctor's office to get your vaccine. So, you know, it's not like your doctor knows, oh, yes, you have 2 confirmed comorbidities. So it's going to be problematic. Implementation, you know, I'm worried about the ethics, but you also got to worry about the public policy around implementation.
Krisha?
Yeah.
So my question focuses more so on certain people who may be opposed to you getting the new COVID-19 vaccination. So I know in the African American community, there's a negative stigma towards government vaccinations. And I believe that this negative stigma originated from incidences throughout history in which African American people weren't exactly treated ethically when given newly created vaccinations or medicines. For example, the Tuskegee syphilis trial. So that brings me to my question: what initiatives can public health officials take to change these negative ideological views towards government vaccinations to ensure that when potential COVID-19 vaccinations are available, African American people will readily get vaccinated?
It's a great question. And, you know, sometimes for these very hard questions, I prefer to say, I'm an ethicist. I don't really have to deal with that part of public health, but that's a cop-out and I'm not going to take it. So look, there is a very long history of abuse of African Americans. They're not the only people, unfortunately, that have been abused by mainly research trials, but it is a serious, it has created serious distrust of the healthcare system. And it's not the only thing that's created serious distrust of the healthcare system. You know, segregated hospitals, not getting the right treatments have created serious distrust. And by the way, for those of you who are empirically minded, there have been some studies that show right after the publication around Tuskegee in the early 1970s, demonstrating abuse of African Americans, actually use of the healthcare system went down, and the actual life expectancy of African Americans, because they became hesitant to use the system, went down. So it has a real material impact on people. It's not just a hypothetical, oh, that's why African Americans are suspicious of the system. So how do you regain people's trust? Well, first thing, we have to be sure that if a vaccine gets approved, it's approved because it's safe and effective, and that we're going to continue to monitor people for safety. Let's be honest, if we get a vaccine approved sometime in the next 4 or 5 months, you're not going to have that much safety data. You're going to have run the trials on 30,000 people, of which 15,000 will have gotten the COVID vaccine. That's not a lot of people by vaccine trial standards. You'll have only 150 incidents of people converting, and you'll have only run it a few months. You won't have run it for 12, 14, 24 months. So we'll be accumulating more safety data as we go on, and people have to understand we won't have the definitive answer early. Second, you have to have the data on which you decide that it's safe and effective public. One of the things I've called for, and I think you'll hear a lot of people, other people have called for it, but I think you'll hear a louder demand, is that the FDA should submit whatever data on a vaccine to a advisory committee, not just entrust the administrator or the FDA commissioner, he's a commissioner, Steve Hahn, to make the decision whether to give emergency use authorization or not, but have an independent advisory committee look at the data and render their judgment. I think that will help. You got to have influencers. You got to have people who are thought leaders in the community, whether politicians, actors, sports leaders, religious leaders. They have to believe, they have to support it, they have to be willing to get a vaccine to show. I think having the president get a vaccine with the vice president, with members of Congress, including members of the Black Caucus and Hispanic groups, that will help. But it's, you know, it's, if you study trust at all and you read literature on trust, it takes a long time to build up trust, and it can be lost overnight, one bad episode. And so there's not going to be a single thing we can do. It has to be an accretion of many things and many people's actions to get us to a situation where people trust the data, trust the vaccine, and think it's not going to make them sick.
Krisha, did you have a follow-up?
Yes, so while we're on the topic of that, do you believe that the representation of minorities in COVID-19 clinical trials is critical to finding a successful vaccination?
It may not be critical to finding a successful vaccination, but it's critical to finding whether the vaccine works the same in all communities. And I mean, the underlying point you're making is a good one, which is that the recruitment so far to the vaccine trials, to the extent that we know it, does not adequately reflect the American population, and in particular, minorities are being left out. And this is a real problem because, you know, so far the COVID vaccine is having a very disproportionate effect on a minority, whether that's a biologically related at all or it's purely social consequence, we don't know. And so being sure that the vaccine works in the African American community, having enough people so that we're sure about the safety in that community, I think that's absolutely critical. And I think more efforts need to be taken to ensure that the enrollment does better reflect the American population.
I think, Zeke, we're going to move to the challenges of reducing cases in the United States. And Sam, do you want to get us started on that?
Oh, yes. So coming from a foreign country, I think it was really interesting for me to watch on TV the protests of American about like how they don't want to stay at home anymore because they want a haircut. So I was just wondering, like, how do you think the American value of freedom and independence have contributed to the country's struggle to bring down the case numbers? Do you think it is possible that some Americans will change their ways in order to deal with the pandemic?
It's a really good question, and I have to say I'm skeptical of that explanation that it's our love of freedom, our love of being independent that has led to this. I think it's really a political problem, and I don't mean to be political here, but this administration has done a terrible job of communicating, having a consistent message, communicating the right message, not just in words, but also in action, not calling governors that have not locked down, and they, you know, the governor in Georgia, the governor in Florida, the governor in Texas initially thought, I've got cover. The president says I don't have to do it. I can not shut down. I cannot discourage people from gathering in large crowds, and on and on. Obviously, that lasted only so long because COVID raged in those places. But I think it's more political leadership than it is, in this case, political values. I think, have you had a different president, had you had Franklin Roosevelt in there, had you had John Kennedy in there, I think the American public would have been really motivated to follow whatever they suggested. It is a problem that we've come to this political moment that we're so divided. But I think even with the divisions, if you had the right president articulating why we do this, that it's going to be 8 to 10 weeks, no, it's going to be hard, you know, going over and over again how hard it's going to be, sympathizing with people, but saying this is what's necessary and here's what's going to happen at the other end if we do this. I think Americans would have done it. And I think that it's not the problem of the values, it's the problem of the leadership.
Thank you for answering. I was really confused when I saw people on TV, but yeah.
Yeah.
Going off of that question, I was wondering, how impactful do you believe that false information on social media has been in the struggle to manage the virus in the United States? And off of that, what do you think should be done to combat that issue?
The first part is easy. The answer is yes. False information has had a very detrimental effect. You still have people saying, well, COVID's not a real, you know, it's made up by the media or whatever. I mean, just insanity. And we know it's insanity just literally from the dead bodies, unfortunately. And we can't tolerate that. And to the extent that there are ways of being in a media bubble on the internet so that you don't have to confront the real data, that's a problem. What to do about it? That I really am incompetent in. I have no idea.
Okay. Tricia?
So I wanted to know, how does economic hardship and health go hand in hand during this pandemic? Would you say that economic hardship has a more substantial effect on health, or does worsening health have a strong effect on the economy? And what does this mean for people who are already in poverty prior to the pandemic?
Yeah, so it's very important to understand, if you look at health outcomes, how long people live, how long, what diseases they get, health care, going to the doctor, going into a hospital, has a relatively small impact on those health outcomes. So the number is about 15 to 20% max. So all the money we spend on healthcare, you know, trillions of dollars, really impacts how long we live, whether we get certain diseases, not that much. All the other stuff, eating right, exercising, not smoking, wearing your seatbelt, and drinking in moderation, those 5 things, which aren't that hard to do, you know, much bigger impact on how long you're going to live. And it's not just for heart disease. A lot of people think, oh, diet and smoking, that's about heart disease, or that's about lung disease. I'm a cancer doctor, right? 40 to 60% of cancer is about, you know, what you eat, what you smoke, and exercise. You know, It's not just lung cancer, right? It's bladder cancer, it's throat cancer, esophageal cancer. Lots of cancers are related to smoking and nutrition, exercise. So those other things, which are worse with poverty. It's hard if you're in poverty to eat well, to remember to exercise, to be able to, have the luxury of not smoking, drinking in moderation, etc. And, I think we don't appreciate that if we actually raise income of people, we'll do more for their health than providing them health insurance. But that's just a fact. And I think it's, we're going to see a big consequence of COVID because we've seen the unemployment rate go way down and now it's popped back up, but it's sputtered out. We don't know where it's going to settle out. We're still way down in terms of employment. We're seeing a lot of people thrown into poverty. I'm a little worried, a lot worried actually. We're going to see a big increase in homelessness because of money and unemployment benefits running out and suspension of evictions going away. And that will have all bad consequences for people's health. So it's mostly the bad economics affecting health. Now, COVID does have a bad effect on the economy because lots of people aren't going out and shopping. They're not going out. I mean, there are some people, restaurants and stuff are back 25, 30%, but there's still the vast majority of people are not using them. And they won't until they think it's safe. Who wants to risk getting sick and potentially dying for a dinner inside of the restaurant? Well, if you're doing that, it seems to me, maybe you're not thinking clearly. So I think a lot of Americans, until we solve the COVID problem, it's going to be hard to return to normal.
Great. I think we'll move to the final topic. Before we do, I just want to remind those that are dialed in that there is that Q&A function. So if you have questions that you'd like me to ask of Zeke, this is the time to do it before we complete the third phase of these questions. And I think this has to do with leadership. You've kind of referred to a bit. It's probably hard not to talk a little politics about leadership, but we'll see where this goes. Jennifer, I'll pass it over to you.
Yeah, so you kind of talked about it a little bit on how the issue with the United States leadership has kind of made COVID more of a political issue versus a public health issue. And I was just kind of curious about your opinion on the tensions we've seen between the federal government and some of the state governments. So one that comes to mind is just how there's tension between Whitmer and Cuomo with like asking for ventilators and the president kind of making it a political issue instead of making it a public health issue. So how do you think we can kind of fill in those gaps to kind of better our outcomes going forward on the pandemic?
You're absolutely right. So, I have had some opportunity to talk to your governor, who I have to say impressed me. She asked a lot of good questions, listened, absorbed it, didn't think she was a know-it-all, and wanted to know what she could do to bring down the number of cases and bring down the deaths in Michigan. And yes, I think it is a huge mistake to pit states against each other for scarce resources like ventilators, like PPE, like testing. That is just terrible because it makes it a zero-sum game. What you want in a leader in Washington is, all right, we're going to have, buy a bunch of ventilators and we're going to move them to where we have a hot spot and we need them. And since we own them, we can take them back when the episode goes down and move them to another hot spot. That is leadership, not having different states have to scramble. Different states have different capacities, their bureaucracies are more or less talented. Fighting against each other is not something that is, they ought to be doing. They really ought to be focusing on getting the services down to the state citizens. And the federal government should help them have those services available, like enough ventilators, like enough masks, like enough PPE. And basically saying, oh, you guys are running the show, you do it. That is, it's irresponsible, first of all. And second of all, it's kind of funny in a president who has repeatedly said, I can do anything. I've got all the control. I've got all the power, which is false. The Constitution limits presidential powers. But on the one hand, thinks he can do anything. And on the other hand, says, well, I'm not doing it. I mean, it's just a contradiction in precisely the area. He does have responsibility. He does have constitutional authority, and he has more power than states do. I mean, the federal bureaucracy, what many people can think it's terrible, bloated, blah, blah, blah. But it's filled, I can tell you this from having worked in the federal bureaucracy for about 13, 14 years, filled with really dedicated people who want to do good. Often they're hamstrung by what they can do because of laws and regulation, but they're typically not evil and not, not want to help people. They typically do want to help. And, part of the problem is figuring out what the right mechanism is for them to actually help. But if you basically say, we're not doing it, it's the federal government, the states have to do it, that is a very, very bad message in this kind of pandemic, which is a national thing. It's not like this is a small outbreak only happening in, southwestern Michigan. That's the only place we have to focus on. This is national, doesn't obey state borders.
Mm-hmm.
Yeah, thank you.
I have a follow-up comment. Like when I saw this, like how the government and dealing with COVID-19, I thought back about how in the Great Depression it was the federal, like technically overseeing everything that brought America kind of out of the Great Depression. So I would have thought the same thing would have happened now.
Well,
but it's not.
It does show you the difference in leadership. And I've said this in other circumstances, and I'll repeat it here. If you imagine, I don't know how much you students are historians of American presidential history, but it's something that I like and occupies my brain a lot. But if you imagine Franklin Roosevelt or Lyndon Johnson in this crisis, the first thing they would have done is set up, 10 task force, a task force on testing, a task force on contact tracing, a task force on therapeutics, a task force on a vaccine, a task force on prevention, a task force on PPE, a task force on glass vials. They would have had, just the whole government working on this problem from every different angle. Would it have been inefficient? Yeah, there would have been some inefficiency. Would it have been better than we're not doing it? Absolutely better. And I think the country would have felt like, wow, this person is just a whirlwind, a tornado of activity happening. And we haven't seen that. All of Franklin Roosevelt's, the CCC, the Tennessee Valley Authority, all of these various interventions he developed, right? I mean, that's what you would have seen in this circumstance with a president like him. Just do something, Here's your goal, get it done.
But before we go back to the students, we did have a question from the audience, Zeke, that sort of speaks to this. And the question is, how do you think a change in leadership at the top, if in fact that's what happens in November, will affect the course of the virus? Can we make a change after we've adjusted to this quote unquote new normal?
It's very interesting. I got almost identical. This is my 5th public presentation today. And I got almost exactly this question, word for word, at 5 o'clock. I mean, I think this is what everyone's worrying. Is the country too far gone? Is it too polarized for a new administration to bring it back? I do think that there is an element of polarization here, which it makes it impossible to bring it fully back. But I think having a president who gives a clear message, tries to restore trust in the CDC and FDA very visibly, wears a mask, does not have crowds for his nomination on the White House lawn with no mask sitting right next to each other, that will have a big difference. For people who are on the fence, don't know what's the norm, what should I be doing, that will make a difference. He will no doubt get criticized, and there will no doubt be efforts to undermine him. Depending on how big an election it is, depending on how much Joe Biden would win by, how much if the Senate would flip to the Democrats, the more it flips, the quieter those voices are going to be, the more you would have Republicans siding and opposing the people who aren't wearing masks, etc. The more we can bring it back. If it turns out to be a cliffhanger and we're debating and the Supreme Court has to rule in mid-December something, then it's just going to be a terrible situation in the country, and it will be hard to get the country more unified and following the public health measures. So it really, really, it is possible to make a change. It's not too late. It'll take time, months. It won't happen overnight. January 20th, it's not going to be, different. The baton isn't going to be passed the way John Kennedy said. Nonetheless, I do think having an administration that can embody the public health measures, that can restore confidence in the FDA and the CDC, I think will make a big difference.
Zeke, we have two questions about how COVID-19 has been handled outside the United States. I'll take one from the audience, and then Fiona has a question from the audience. It's the question is, are there significant variations from country to country on how they define a death as a COVID death?
There is some variation. It's not as great as you might think, and I think there's a lot of hullabaloo about, we have more COVID deaths just because we classify them. One of the things that people like me look at is what's called excess deaths. If you look at the number of deaths in a country between 2015, 2016, 2017, 2018, 2019, a 5-year period, you get a baseline. What are the number of deaths? And then if you look at the number of deaths we have now, we have excess deaths, several hundred thousand. Some of those are going to be COVID deaths. Some of those are going to be deaths from like heart attacks or cancer because people have forestalled getting treatment. If you need an exact number of directly by COVID, you're not going to get that. And partly, there are lots of reasons, lots of deaths that might look like respiratory illness that won't be classified as COVID. But also remember, one of the things we've learned after the initial deaths were happening is, look, COVID induces a lot of clotting and strokes and heart attacks. We wouldn't have classified initially strokes and heart attacks as COVID-related deaths, and yet they do seem to be COVID-related deaths. So I think the up-down goes both ways, and what you really want to keep your eye on is the excess mortality. How much more than what we would have expected had we looked at the last 5 years of data? How many more people are dying? And it's a big number, more than 200,000.
Fiona?
So taking back to the topic of leadership with COVID-19, is there a country whose government's leadership during this pandemic could be seen as the model for all countries? And if so, what specifics about this country's response make it the ideal?
I'm not sure I can answer the ideal. I can answer better. First of all, there are a number of countries that actually have done a really good job. And I'll mention a few of them, and then I'll concentrate in on one that I know better. So look, New Zealand is, less than 500 deaths, less than 500 cases, not deaths, cases. I think it's still in single-digit deaths. Maybe it's in low double-digit deaths, but 5 million people and hardly anything going on. Greece, of all places, done a remarkably good job. Why did Greece do a remarkably good job? Healthcare system is terrible, and they were very worried if they didn't get this under control, they would easily overwhelm the healthcare system. Lots of people would die. They put on the public health measures, made people stay at home. Remarkable. And you know what happened? Faith in government went way up in Greece. Government worked. It did what it was supposed to do. There's a crisis. Government responded with the crisis. And Greece was way better than Italy, Spain, France, some of the other countries, Britain, that looked down on Greece over the last 5 or 6 years because of the financial crisis. So the public, like we're good. We know how to do these things. We can actually respond. So it does show you that leadership makes a difference, and leaders get credit for responding well. There's so those of you who study international relations, you know, there's a notion of soft power, right? People respect you, are attracted to you because of the way you respond. You're not getting attraction from other countries just because you've got more muscle and better weapons. Lots of soft power attached with a good response to COVID. And Greece and New Zealand are two examples. The country I would pick out is Taiwan, because as I like to say, Taiwan could have been a disaster. It's less than 100 miles off the coast of China. It had 1 million people working in China. It had scores of flights back and forth with China every day. It could have been terrible. You know, the virus come and just rage across the whole island. But Taiwan did not have a disaster, and it didn't have a disaster for 3 reasons. First, they were very suspicious of the Chinese. They survived SARS in 2003, 2004, and they knew that the Chinese screwed it up. And so they weren't going to be caught flat-footed on the next time. And if the Chinese had a virus, they were going to take it very seriously, no matter what the government was saying. Second, they stockpiled. They didn't just say, oh, we're going to take it seriously. They had PPE. They had lots of capacity to respond to a pandemic, and they didn't let it go away. We had built up capacity and then sort of took our attention away. They didn't. Third, they had a face mask culture. People wear face masks. They put face masks on, probably limited the spread substantially. And the last thing is they have this health card that allows the government to find out when people are going to the doctor, what the doctor's doing. And so they were easily able to identify people who had respiratory symptoms but were negative for flu and get them in and get tested for COVID. Second, they actually took the health card and matched it with the immigration card to find out who'd been in China, who'd been in Wuhan, and get those people into testing to find out if they were infected. And people who tested positive were isolated, and isolated rigorously, put in an apartment. They were, I think, called twice a day to make sure they were still in the apartment. They tracked if they went out of the apartment or if the phone didn't move, so suggesting they might have left the phone and gone out. They actually called them. They were very serious about this. And the consequences, you know, life is normal in Taiwan. Mm-hmm. And you and I can't go there for a reason.
We have a question, Zeke, related to vaccines, but not COVID. Will we have enough flu vaccines amid the fears of running out with an anticipated surge in people seeking flu shots?
Great question. So they've upped the production. Have they upped the production enough? They're not producing 300 million doses, I can tell you. I think it was 175 million that they're going to produce, or 190 million, which is substantially more than they normally do. I could be wrong. In a normal year, 2/3 of children get it. So, you know, on average, that's something like 50 million kids, and 45% of adults get it. I think they're anticipating a lot more. I can tell you, I've already got my shot. I got my shot 2 weeks ago. So I would urge all of you, get your shots.
You know, you mentioned about being prepared, and Taiwan was prepared. Were you surprised at how ill-prepared we were as a country for this?
I was, and partially, you know, I understand. Well, let me put it. After SARS, we had a Secretary of Health and Human Services, Mike Leavitt, who had been governor of Utah, and he took it very seriously, and he asked for a report, commissioned a report on how to respond should we have a pandemic, and he was thinking flu pandemic. And that was done. It was updated in 2008 because the initial recommendations on how to distribute the vaccine turned out to be unethical and wrong. I criticized them and they revised it. And then periodically we've had updates. I think the last one was 2017, just before Obama left. You know, Obama, there was a legacy there. I had seen President Trump. I actually made a suggestion to him. I told him that a flu pandemic was a serious problem, that he should get an expert in the White House to work on these biological threats. I suggested a man named Admiral Tim Zimmer. He was the man who headed the Presidential Malaria Initiative, did a fantastic job with that. They actually hired him, but then they eliminated his position.
Mhm.
And that, you know, if you don't have someone sitting there worrying about this problem and knowing how important this problem is, yes, it's a low probability event, but it's a high magnitude impact event. And we in America are very bad at focusing on those kind of events. Low probability, yeah, it hasn't happened this year, hasn't happened last year, let's stop worrying about it.
Mhm.
That is our problem. And it's tied to the way we budget at the federal government, the way we plan, what people get credit for. We need to be better. And I hope COVID, if nothing else, we need to find whatever that set is of low probability but high impact events, and really entrust the group to worry about that, put in place how to solve those problems.
Mm-hmm. Zeke, I think we're coming to the end, but want to give you the last word. Can you tell us what you think 2021 is going to be in store for us?
I think 2021 early on is not going to be better. I think, you know, January, February, we're going to be inside. I think we're going to have outbreaks. I'm really worried about the winter in this country, beginning really in a month or two. I think towards the end, I keep saying November 2021, I think we'll get enough vaccine out that things will be good. But, and Jim Wilson can tell you this better than I can, remember how many people we have to vaccinate depends on how effective the vaccine is. If the vaccine's only 60% effective, we're going to have to immunize 83% of the population to get herd immunity. And that's a problem. And if the vaccine doesn't last a long time, it lasts 6 months, that's a big problem. So there's a lot of unknowns yet to go, and having a vaccine is not the only solution. I'll say one last thing, which is I think one of the things that has surprised me a lot is how little we focus on a preventative drug, something you might take that would prevent you from getting sick. You know, I don't know how many of you, if you've ever traveled to Africa, but I travel a lot to Africa, and you know, you take a preventive pill for malaria, so we just haven't spent a lot of time worrying about getting a preventative pill, but that could be effective. Now, I've heard that aerosolized interferon in the nose does seem to be very protective, and you know, it's a generic drug now, and if it's given aerosolized in the nose, you really don't get the flu-like symptoms that people hate when they take it by injection, and that might be a good preventative. But in addition to a vaccine, we should be worrying about other treatments and interventions, and I think there hasn't been sufficient attention.
Well, Zeke, I want to again thank you for participating in the webinar series and spending time with our students and our community. And
great.
And again, thank you for everything you're doing to speak out on these issues. And thanks to students for your question and answer. And everyone have a good night, and say hi to your brother on behalf of all of us.
Thank you very much, and it was really enjoyable.
All right. Thank you.
Great. Take care.